Welcome to The Explainer. Today we are cracking open a microscopic true crime file to investigate some of the absolute most common and, honestly, most cunning bacterial pathogens known to medicine. We're talking about staphylococcal infections. And trust me on this, the way these organisms operate, it is nothing short of a highly coordinated biological heist.
So let's dive right in with a pretty chilling question. What actually happens when our microscopic neighbors decide to go rogue? Most people think of infections as something you catch from the outside world, right? Like a sneeze, a cough, a dirty surface. But what if the call is coming from inside the house?
To really get this, we first have to understand that these bacteria are actually part of our normal commensal flora. Basically, these are bugs that normally just chill out, living peacefully in places like our nose or right on our skin. Fact is, between 25 and 75% of you watching this explainer have these bacteria hanging out in your nose right now. Perfectly healthy, completely unaware. They're just hitching a ride. But under the exact right circumstances, that peaceful coexistence completely shatters.
Section 1. Meet the microscopic suspects.
Every good investigation needs a lineup, so take a look at these guys. Meet the beautiful but super deadly Staphylococci. Notice how they bunch up in those really distinctive grape-like clusters? Now, they're non-motile, which means they don't swim around and they don't form spores. But do not let their stationary nature fool you for a second. These gram-positive cocci are incredible survivalists. They are tough enough to handle temps up to 50 degrees Celsius, extreme drying, and even super high salt concentrations. They can just sit on a dry surface for ages, just waiting for their moment.
Now, out of the more than 40 different species out there, we've really got 3 primary culprits, and each one has very specific targets and lab signatures. Staphylococcus aureus? That's our prime suspect, highly pathogenic, usually found in the nose. Then there's Staphylococcus epidermidis. This is a skin commensal, but loves to attack immunocompromised patients or latch onto foreign medical devices like catheters. It's exactly why hospitals have to be so paranoid about IV lines. Finally, we've got Staphylococcus saprophyticus, which is part of the normal vaginal flora but is a massive player in genitourinary tract infections. And if you look at their lab tests, S. aureus is the only one here that produces the coagulase enzyme and ferments mannitol. We'll actually see that in action a bit later.
Section 2. The bacterial arsenal.
Like I said earlier, this is not just a random smash and grab. These microscopic criminals have a highly evolved step-by-step playbook. Step 1 is transmission. They usually catch a ride through direct person-to-person contact, or they use fomites, contaminated stuff like bed linens, clothes, or hospital towels. Step 2 is colonization and adhesion, literally grabbing onto the host's cells. Step 3 is invasion, pushing deeper into the tissues. And finally, step 4 is tissue injury, which is when the real visible damage hits.
But how on earth do they survive our highly trained immune system while they do all this? Well, they wear literal structural armor. They've got this capsule or slime layer that actually inhibits phagocytosis. It physically stops our white blood cells from eating them. They use teichoic acid to stick to our mucosal cells like superglue. But the absolute most devious trick? Protein A. This protein binds directly to the Fc portion of our IgG antibodies. In plain English, it acts as a literal shield against our body's antibodies, practically blindfolding our immune system so the bacteria can't be targeted. It's wild.
So what about their offensive weapons? We can split their arsenal into 2 categories: enzymes and toxins. The enzymes act like lockpicks, helping them spread through human tissue. They use coagulase to build a fibrin wall around themselves, literally hiding inside a blood clot. Meanwhile, hyaluronidase acts as a spreading factor, melting right through our connective tissue. But the toxins? Those act like biological bombs. Toxins like enterotoxins and TSST1 are called superantigens. They bind non-specifically to white blood cells, and that triggers a massive, totally uncontrolled overproduction of immune cytokines.
Section 3. Crimes against the body.
Let's look at the actual clinical evidence once they breach our defenses. You've almost certainly seen these localized inflammatory attacks in real life. On the one side, we have a painful suppurative skin abscess. On the other, a really swollen sty right on the eyelid. These are local, pus-filled lesions. The bacteria have essentially set up a local camp, and your immune system is violently fighting them right at that specific site.
But when they deploy those toxin weapons we just talked about, the crimes go from localized bumps to severe, devastating systemic conditions. We're talking about scalded skin syndrome, which mostly hits babies and young kids because an exfoliative toxin makes large areas of their skin literally peel away. We also see the systemic rash typical of toxic shock syndrome. That's driven by that TSST1 superantigen, which can rapidly cause hypotension and even heart and renal failure.
And here is a crazy fact. They don't even need to be actively living inside you to launch an attack. Food poisoning is a classic staph crime. If someone carrying the bacteria has poor hygiene and handles food, especially carb-rich stuff like cakes, pastries, or milk, and just leaves it sitting out unrefrigerated, the bacteria will multiply and pump enterotoxins right into the food. And these toxins are heat-stable. Our stomach enzymes can't touch them. Because you're swallowing a preformed toxin, it hits you fast. We're talking 1 to 8 hours later, you are hit with brutal nausea, vomiting, and diarrhea. Noticeably though, usually without a fever.
Section 4. Medical detectives and diagnosis. With attacks this dangerous, how do our medical lab detectives actually catch these guys? Well, once a sample of pus or blood is collected, step 1 is the catalase test. It's a brilliantly simple biochemical reaction that sorts the staph suspects from the strep suspects. The lab tech just drops some hydrogen peroxide onto the bacteria. Now, because staph produces the enzyme catalase, which it uses to defend against our own white blood cells' peroxide attacks, the sample will visibly fizz up and produce bubbles. Streptococci, they are catalase-negative. They do absolutely nothing.
Next, the scientists have to nail down exactly which strain of staph they've caught. They grow the evidence on a selective media called mannitol salt agar. The stuff has a super high salt content that staph just loves. But the real magic is how it unmasks our main culprit. S. aureus ferments the mannitol in the agar, and that changes the pH. The result? It leaves this glowing golden yellow footprint right on the plate. It completely gives itself away from the other harmless skin flora.
Section 5. Fighting back and superbugs.
So we've got the diagnosis, now we fight back. But these bacteria are absolutely not just taking the hit. They are actively fighting back with dedicated resistance tactics. The bacteria produce an enzyme called penicillinase. This enzyme has one job: hunt down the beta-lactam ring, which is the structural core of penicillin and cephalosporin antibiotics, and literally break it to pieces. Because of this targeted counterattack, a staggering 80% of hospital staph strains are now entirely resistant to penicillin.
This constant back-and-forth evolutionary arms race brings us face-to-face with the infamous MRSA, Methicillin-resistant Staphylococcus aureus. When penicillin failed, we made methicillin. Well, S. aureus adapted to that too. Now, MRSA is a highly resistant superbug that needs heavy-duty drugs like vancomycin to treat. And it used to be just a hospital problem, known as HA-MRSA, but not anymore. It's broken out. Community-acquired MRSA, or CA-MRSA, now accounts for about half the cases, spreading in everyday places like gyms, locker rooms, and daycares.
So, we're going to wrap up this explainer by leaving you with a critical and kind of scary question. As bacteria like MRSA just keep upgrading their structural armor and their biological weapons, how will humanity's medical detectives manage to outsmart these rapidly evolving superbugs before we literally run out of effective treatments? It is an ongoing true crime saga happening under the microscope every single day, and the stakes could not be any higher. Thanks for joining me on this explainer, and always keep questioning what you think you know about the microscopic world around you.